afternoon, everyone. I am Ursula Gavransky, and I'm the Espnic Nursing President. And I'm from Italy, from Bambino Gesù Children's Hospital, where I am a nurse coordinator for the Professional Development, Education and Research Unit. And today I will be co-chairing this session on pediatric intensive care syndrome with Dr. Simon Nadeau. So good afternoon and welcome to everyone.
Good afternoon, everyone. I'm Simon Nadeau. I'm the past president, or one of the past presidents of Espnic. I'm a consultant in paediatric intensive care at St Mary's Hospital and Imperial College London. And I have the pleasure of co-chairing this session on post-intensive care syndrome with Ursula. And it's a great pleasure for me to introduce our first speaker, who is Professor Martha Curley, who's the nursing chair of pediatric nursing at Children's Hospital of Philadelphia and professor at the University of Pennsylvania. Professor Curley is going to talk to us about the life after critical illness toward an understanding of pediatric post-intensive care syndrome. And just to tell you before she starts that if you have questions, there will be a panel towards the side of the screen that you can post questions on while the talks are going on. And we can ask those questions in the question and answer session at the end of this, end of the two talks. So Professor Curley, over to you.
Thank you. And thank you so much for this opportunity to share with you some of the work that really both of our speakers today have been actively engaged with, and that's post-intensive care syndrome, life after critical illness in children towards a new understanding of PICS-P. I want to start by, again, thanking you. I wish I could be where we were supposed to be in Greece. We were supposed to be someplace fabulous, but we're not there, but we're here remotely. So hopefully sometime soon. I do have disclosures. The work that I'll be talking about today has been funded by the National Institutes of Health in the United States, the Restore Follow-Up, Restore Cognition, and the PICS-P studies. So again, I bring greetings to you from the United States at both the Children's Hospital of Philadelphia and University of Pennsylvania School of Nursing, where at CHOP, I'm chair of nursing science within the organization. So I'm excited to be able to talk to you about really this third revolution in critical care. Jack Awashina published on the 70s going into the 90s, and today the revolution from saving the ill to think about how we can coax people into death in a humane way, but now thinking about how our patients survive critical illness, where their lives are not the same as they were before, but not necessarily all that less. So it's up to us to think about not only what happens in the intensive care unit, but beyond the intensive care unit. So I want to talk today in my time with you about PICS-P, thinking about potential recoveries that our patients experience, and then hold a carrot out there for that. Perhaps once we get this thing better understood, we could start to intervene and to hopefully minimize this syndrome of post-intensive care pediatrics. And I think Joe's going to talk a little bit about that next. So again, Jack Awashina and Mark from University of Pennsylvania reminded us that, and this is an adult model, that when you are sick with an acute illness, there's lots of hazard within the environment that includes bed rest and hospitalization in and by itself. Okay, so immobility, diet issues, very much alterations in plasma volume, decreased ventilation, social isolation, and the sedating medications themselves contributes to weakness, cognitive impairment, new organ dysfunction, psychological problems that end up increasing the risk or mortality and really prevents people from returning to their roles in society, seeking reoccurring healthcare needs, and then really burdening up caregivers in and by itself. So this is an adult model, but I would propose that the pediatric model is somewhat similar. This phenomena of post-intensive care syndrome was articulated as new or worsening problems in physical, cognitive, or mental health status arising from critical illness and persisting beyond the acute care hospitalization. And the term can be applied forward to the survivor and also the family member with PICS-F. This work comes out of the Society of Critical Care Medicine, the Thrive initiative, in which I was a part of from a pediatric perspective. Dale Needham's work out of Hopkins articulated this post-intensive care syndrome that includes both the family and the survivor, and calls attention to the mental health issues of both family and survivor, along with patients' cognitive impairment and physical impairment. So, you know, part of this is this risk-benefit ratio of wonderful that you survive critical illness, but now we want to focus on the quality of that survival and going back to how we can create an environment within the intensive care unit that pays it forward downstream to improve outcomes. So thinking about that, in the adult world, there have been strategies to minimize PICS. I won't spend lots of time with this because Joe will. The ICU liberation movement that is focused with this A-do-F bundle that looks at assessing and preventing and managing pain, both spontaneous awakening trials and breathing trials to get people up and engaged and off the ventilator as quickly as possible, considering what's going on with their analgesia sedation, considering how delirium comes to play, getting patients up and moving, and really including the family engagement and empowerment within the process. In children, we know that survival has increased substantially, but mortality alone is in agreement, an insufficient metric of how well we're doing within pediatric critical care. Because we do know that some of our survivors are physically deconditioned, cognitively impaired, and emotionally distraught. And that this not only affects the patients, but also the parents and the siblings. And we don't have a lot of really good data that really provides us with a comprehensive understanding of PICU morbidity among survivors. So our big research questions are, do our patients and families experience this? What are the common problems? Is there a pattern to how they come to play? What is the trajectory of recovery? What cohorts are at greater risk, and what can we do to mitigate these negative consequences? So we started this work, at least in the collective, back at the World Congress in Toronto in 2016, where we put together a stellar cast of people at the time who were really engaged in life after critical illness. And we put this group together to address these 4 points. And we wrote out this paper that was published in 2018 that reviewed the state of the science at that time. And then Joe, myself, Nidhi Pinto, Janet Reddick, and Julian Corville went on to create our conceptual framework for PICS-P, where it starts by looking at what the patient's baseline status is, what their ICU experience is like, and what's their recovery like from a physical health, cognitive health, emotional health, and social health perspective, knowing that all of this includes within families who are developmentally growing, within children who are also on a developmental pathway. So what's the difference and what is the impact of PEDS critical illness on kids who are not finished when we take care of them from a developmental perspective? And what is their recovery like? And this again goes back to Jack Washington's work on, do kids get better? Do they get worse? Do they vacillate, or they just kind of plateau? And that's kind of where we laid out this framework so that we could start investigating it systematically. And what I want to just talk briefly about are these 4 points, and then a little bit of the work that I've done within the Restore clinical trial to kind of try to unpack this and to think about how we can move forward. So considering the baseline status, not all kids end up the same way. And this is work that was published out in the adult world. Hannah took the lead here, Hannah Wallish. You have to consider, you know, how the kids were or how the individuals were before they came into the ICU, and then how big of an ICU hit did they take, and then what to expect afterwards. So baseline status of the child and the family has to be considered when we look at long-term outcomes after critical illness. What happens in the intensive care unit in and by itself, again, how one. So when considering post-intensive care syndrome, you need to start with the patient's baseline status. And this work comes from Hannah Walsh's work, who proposed what patients end up looking like post-intensive care hospitalization, whether or not they would have preserved function, functional decline, or death or severe disability has a lot to do with their baseline status. Their condition pre-index hospitalization. So were they healthy or were they not? And then how much of a hit did they take within the intensive care unit, lower criticality or higher criticality, and that would move it forward. So baseline status has to come into play. So that leads to what happens within the pediatric intensive care unit. And I'll leave Joe to discuss this, but we are working with patients now who are more awake. We are implementing delirium protocols to control the intensive care environment, getting patients up and moving even when they're cannulated on ECMO. But these practices are highly variable. So one ICU cannot be compared to another ICU until we can embed some of these practices as a standard of care within the intensive care unit. When we look at what happens after the intensive care unit with this developmental impact, we need to figure out who's at risk. Are there more than 1 or 2 or 3 different post-PICU phenotypes? Are there outcome clusters that we need to consider? What is the developmental impact when somebody is sick when they're 3 years old versus when they're 13 years old? And what post-interventions or care delivery models must be built to improve the PICU recovery? So the trajectories, again, with Jack Awashina's work, most patients in pediatrics do well. They may take a big hit, so they have an acute loss of function, but then a partial or full gradual recovery. They have a slow burn where they have new persistent or rapid decline in function, or relapsing occurrence that lead to acute exacerbations and readmissions over the years to come. Research gaps for PICS-P is really the mechanism of injuries, you know, areas for prevention, and then looking at the trajectory of illness over time. And this was an excellent paper published about where we need to go to better articulate PICS, and specifically from our phenomena, PICS-P. Great website at Johns Hopkins, but in kids, we need epidemiological studies to define the scope of problem, studies about transitions of care from hospital to the community, community to schools that include the community. What outcome measures should we be using, and the best approaches to post-intensive care? So as a backdrop to some data that we do have, I'd like to situate a little bit of my comments into the Restore clinical trial that had as a specific aim to compare post-discharge quality of life and emotional health in patients who were enrolled into this cluster randomized design of approximately 2,500 patients. We measured kids at 6 months by structured telephone interview. We looked at their health-related quality of life and their post-traumatic stress. We enrolled kids that were about 2 years of age. About a quarter had baseline cognitive and functional impairment, 3% risk of mortality. They had really severe PARDS, multisystem